Welcome, and thank you for joining us today for the SPH Analytics webinar, Payer-Provider Collaboration to Achieve the Triple Aim. We will have a question and answer session following our presentation today. Please type any questions you have for our presenters into the Q&A tab of the WebEx portal at any point during the presentation. We will also be recording today's webinar and will make the recording as well as the slide deck available to our attendees within the days following the webinar. Next, I'd like to go over the agenda for the webinar today. As you read the items on the agenda, please note that our learning objectives today are to understand what is driving the need for closer collaboration, creating a frictionless experience for the provider workflow, how to overcome payer-provider collaboration challenges, strategies to close current technology gaps, and to learn best practices from other organizations. Now I'd like to introduce our first speaker, Dr. Roki Chauhan. Dr. Chauhan is a healthcare consultant with deep experience in physician leadership, physician collaboration, strategic planning and implementation, quality improvement, healthcare cost management, account management, relationship building, and leveraging data and analytics. He is the former Senior Vice President and Chief Medical Officer of Premera Blue Cross, located in Washington State. During his 15-year tenure at Premera, he was responsible for senior corporate medical leadership, strategic planning and implementation of clinical programs, including medical and pharmacy utilization management, case and disease management, and collaborating with providers in Washington and Alaska to improve quality of care based on data and analytics. Dr. Chauhan is a graduate of Tufts University School of Medicine. Welcome, Dr. Chauhan.
Thank you. So what I'd like to do today is I want to set the stage with some background information that I think will be helpful for you as we move through the rest of the presentation. I was a health plan executive for many years, and I'm continuing to work in the industry, and I think for the first time I'm beginning to see an increasing awareness by providers and payers that they need to work more closely together. Go ahead and move to the next slide, please. And so when we stop and think about what's driving the need, there's a variety of things. One has to do with quality measurement and improvement. In addition, there's factors revolving around risk adjustment that impacts the health plans. In addition to that, many of the health plans, including CMS, are moving to value-based reimbursement. So as you all know, there's this shift in paying for volume to paying for value. And this in turn leads to improvement in terms of growth and retention of membership for the health plan. There's going to be information shared with members about their personal experience, and this is becoming even more and more important as people are starting to report in different venues their experience, not only with their health plan, but with their providers. This in turn, I think, has led to improvement in the relationship between providers and health plans. And one of the things that we hear many times from folks is that, the provider community has a lot of the information that they already need in their electronic health record. But many times they don't have the pharmacy information, and that's something that a health plan can contribute to a provider very easily in today's world. And then, of course, as we all know, there's all sorts of, external pressures, be it from employers, from regulators, from the government. All of these are leading to what I would call shared decision-making that's happening at a higher level, not the kind of shared decision-making that you might be thinking about in terms of between a patient, but between providers and health plans. So I want to spend a few minutes talking a little bit about some things that are important to a health plan in terms of quality. Go to the next slide, please. And I'm going to apologize in advance to the folks on the phone who may already know this, but in essence, there are two dominant players in the marketplace. One is NCQA, and the other is CMS, which does the measurement for Medicare Stars for both the Medicare Advantage plans as well as the prescription drug plans. But what's not on the slide, and before I go there, the two indicators that are used a lot are HEDIS and CAHPS. But what's not on the slide is that individual states have also developed star ratings for their commercial and their exchange memberships over the past several years. In California, for example, there's the California Office of the Patient Advocate that ranks health plans based on HEDIS And they don't use the CAP survey. They use something called a patient assessment survey, which is very similar. They rank HMOs, they rank PPOs, they rank provider groups, both on a commercial basis and a Medicare basis. And that's just one example of one state, and I'm sure those of you know of similar examples in your states. And I think that what's becoming more and more apparent is that there is an increased need for being a top echelon performer, so to speak. Let's go to the next slide, please. So NCQA accreditation has changed over the years. As you can see from the pie diagram here, half of the score of the NCQA accreditation scores are based on the policies and procedures and the oversight activities that happen within the health plan. But the remaining 50% have to do with outcomes in terms of quality and patient experience. Once again, HEDIS and CAP scores make up a total of 50%. And a provider organization might say, well, why does NCQA accreditation for a health plan matter to me as a provider? And I think one answer is that NCQA accreditation has market cachet with employers. And so if a health plan can attract more employers, that in turn attracts more members, which then in turn allows for continued growth of a provider practice, for example. Next slide, please. The other area that I wanted to touch on briefly is Medicare Stars. So CMS has a rating system for their Medicare programs, the Medicare Advantage plans, and the Medicare prescription drug plans. And you can see here that there are several categories in which they measure the performance of the health plan and the provider. Next slide, please. It's a little bit of a busier pie diagram than the previous one for NCQA, but essentially you'll see again that HEDIS and CAPS make up a large percentage of the score. And then there's also something new, which is called health outcome surveys, which is relatively new. And that has to do with, does the patient feel that their health has improved over the past 2 years? In terms of member satisfaction, it's not just CAPS, it's also the satisfaction, it's not just health plan CAPS, it's also the satisfaction with the health care they receive in terms of timeliness of having to have an appointment with their provider. And so this measure for Medicare Stars actually impacts both providers and health plans. There's a lot more detail behind this that many of you are probably familiar with. An important point to note is that the metrics that are all used for Medicare Stars are all weighted. And so some of them have a higher weighting, such as health plan quality improvement has higher points, as does something like, is the patient's, diabetes being properly controlled. I want to move on to the last area that I'm going to talk about, which has to do with risk adjustment. Next slide, please. So first I want to touch on Medicare Advantage risk adjustment. And basically what this has been designed to do is to ensure that patients are receiving high quality care. And so a health plan who has Medicare, that offers Medicare Advantage, basically will assign a value or risk score to each beneficiary. And it's based on their, demographics, their health status, and many other factors. And what that does is it can reflect the cost, there's a predicted cost compared to those of an average beneficiary. So someone who has diabetes or hypertension or chronic lung disease, et cetera, is going to have a higher risk score. And why this is important is that the risk scores are then multiplied. There's this complex system that they use to determine payment to the health plan. And this is then added in as a quote-unquote rebate for plans that are trying to improve quality of care. And again, this is part of, Medicare's and CMS's desire to move towards paying for value versus paying for volume. Next slide, please. On the other side, on the commercial side, there's also something that is oftentimes referred to as commercial risk adjustment. This came about as a result of the Affordable Care Act. And essentially what this did was it was an attempt to stabilize the risk. They wanted to ensure that health plans didn't get more patients with high risk subscribing to their health plan. And the reason is they want to be able to provide services to a diverse population, and they want to stabilize the premium so that, a health plan doesn't go out of business because they got sicker patients. So what they do is the risk adjustment model basically redistributes money from insurers with healthier patient populations to those with sicker patient populations in each individual state. And what's critical here is, and health plans have, started working more closely with providers in this regard, because the provider, in addition to performing their normal task of taking care of the patients, they actually have to document what they did and code appropriately for each calendar year. The next slide gives a couple of examples of how this might look. So you'll see here that member A, for example, and these are actual examples taken from health plans. Member A, for example, was coded for diabetes in 2015, but in calendar year 2016, that patient had 4 visits. The coding was for asthma. There was no diagnosis of diabetes during that calendar year. Therefore, that risk score would be different than if they had actually coded for both diabetes and asthma. The third example, patient was coded for diabetes, 8 times prior to 2015. For whatever reason, had 2 visits in 2016. Obviously, in this case, in the cases above this, their diabetes did not go away, but the office charges from the providers were only diagnosed as, on the claims forms, as chronic kidney disease or congestive heart failure. And so in this case, someone with chronic kidney disease, congestive heart failure and diabetes is going to have a much higher risk score. That's one of the reasons that you start to see health plans working more closely with providers to determine accurate diagnoses so that they can make sure that they are properly documenting and submitting to CMS accurate information about their membership. So I'm going to stop here and turn it on to the next speaker.
Thank you, Dr. Chauhan. Our next speaker is Suzanne Kogan. She is Chief Commercial Officer of SPH Analytics, and she has more than 2 decades of professional experience leading healthcare technology and service companies to double and triple digit growth. Suzanne joined SPH in 2017 from Orion Health, where she was Vice President, Sales and Solution Consulting USA. Before Orion Health, Suzanne was a co-founder of Shareable Inc. and served as its Vice President, Sales Marketing and Business Development. Suzanne has a high-tech MBA from Northeastern University and a BS in International Marketing, German, and French from Dublin City University. Welcome, Suzanne.
Thank you. So if you could go to the next slide, please, Terry. So now that we've heard about some of the business issues driving the need for closer collaboration between providers and payers, what I'd like to do is walk through some of the key concepts and use cases and technology solutions that we're seeing take shape in the market. So first of all, I'd like to provide some definition around the notion of collaboration. About 2 years ago, I was starting to see payers strategizing, or in some cases, implementing solutions to retrieve EMR data electronically from providers for the purpose of better identifying gaps in care and supporting their providers in value-based plans. And I saw a presentation by Gartner at the National Blue Summit in 2015 that defined the term clinical data integration, and the definition being the acquisition of clinical data from an EMR and integrating that data with payer-owned systems and processes in order to provide a more complete and timely view of a member's health, which would then result in better quality, as we've just heard Dr. Chauhan discuss. And if you look to the right of this slide, this is a Gartner Hype Cycle, which is a tool that Gartner uses in many industries to convey which concepts and strategies are emerging and which are moving into the mainstream. And at that time, in 2015, clinical data integration was in the early phases, and they predicted that it would move into the mainstream within the next 5 to 10 years. Now, I know from working with many payers over the past couple of years and hearing presentations at recent conferences that the need for this clinical data integration is now quite widely recognized, but a lot of organizations are still trying to identify the methods to achieve it, as it involves, of course, a lot of complexity, which I'll explain in a minute. Next slide, please. So Gartner went on to describe the most common use cases for clinical data integration, and these largely mirror what Dr. Chauhan just described. So prior authorization and utilization management, this would be enabled if EMR data can provide the additional information needed for decision making. And with EMR data, the idea is that the information would be available in near real time, which would greatly reduce the time frame for the decision making. Quality measurement and improvement, as we've just heard, this data is extremely valuable to payers to help with their HEDIS and STAR ratings. And if you consider the alternative, which is sending chart reviewers to practices to audit charts, and the expense of that and the burden that that places on the practice, not to mention the fact that when the chart review happens at the end of the year and care gaps are identified, there's usually no time left in the year to bring patients back into the clinic and close the gaps, as compared to having the full picture of the member and their care gaps year-round that you get with having electronic access to EMR data. That also ties into risk score optimization and understanding what gaps exist in the coding to ensure that the risk score or risk adjustment factor is properly calculated. For advanced analytics, more comprehensive and clinically rich data from an EMR undoubtedly would improve a health plan's efforts to analyze its member population better, stratify them, understand which members are high risk and rising risk in order to take earlier intervention, and basically enable the plan to become more predictive and more proactive with the health of their member population. And then finally, care management. So care managers within a payer organization typically operate only on claims data, and introducing clinical data to their workflow would greatly help them. Next slide, please. So if I were to boil down what we hear from our clients, what we hear from industry analysts and out in the market in general, there are two major themes that emerge. One is the need for access to clinical data from provider EMR systems, as I've just described. It can be very challenging to access this in a cost-effective manner and without disruption to the practice, particularly when you're a payer that doesn't have or contract with a majority of the provider's panel of patients. So you're a smaller market share for that particular provider. The other common theme is helping providers who are in value-based contracts succeed. I've worked with many provider organizations who have great quality incentives in their contracts with their payers, but they just don't have the means, the time, the resources to meet them. And the typical scenario is they get multiple spreadsheets a month from each payer that are retrospective. They're hard to translate into action items for busy providers, and they really need tools that integrate more into the provider's workflow and make it easier for them to identify care gaps across any patient that they see, not just health plan A's members, and to do so proactively. So either as the patient is in the office or by reaching out to patients who have gaps and haven't come into the office. Next slide, please. So I just wanted to outline a couple of examples that I've come across recently among some specific payers. Aetna, which is, some of you may have seen the ads rebranding to "You don't join us, we join you." They're very proactively collaborating more closely with providers, and they've got several joint ventures underway. And they're tackling the issues of in the past having been much more reactive rather than proactive. And of course, being reactive is essentially the byproduct of only working with claims data. They're tackling the lack of predictive analytics and not having them fed by clinical data. And they're tackling the lack of aligned incentives. Then there's Blue Cross Blue Shield of Massachusetts. They have something that they call the Alternative Quality Contract. They've had value-based contracts with providers since 2009, so they were quite early on in this value-based reimbursement world. And recently, they ranked in the top 10 health plans by NCQA. They have been shifting from moving from in-house case managers to case managers that are part of the provider practices. And this is a journey that I'm starting to see several health plans move along, and it absolutely requires data sharing and the flow of clinical data to the claims data to the practices and clinical data to the payer. And then among other payers we've worked with over the past couple of years, these use cases at the bottom of the slide have emerged time and again, very similar to what we've heard from Gartner. So enabling access to more complete medical records for audit purposes, supporting their value-based provider partners by giving them a more holistic view of the medical record, the transitions of care use case, being able to, at the payer level, understand holistically and have a clinically rich view of the patient during transitions of care, managing overall pop health, closing care gaps, and improving the in-house care management. And two quotes that I've heard recently that have really stuck with me and really embody the themes and challenges that we're talking about. Over on the top right, one payer said, if we could improve quality and cost information, such as prescribing patterns, provide these to the provider at the point of care, that would be very powerful. And then another payer said that they want to become as mature in dealing with clinical data as they are with claims data. Next slide, please. So summarizing the common technology gaps and friction, I think they can really be boiled down to three major challenges or categories of challenges: requests from multiple payers, care gap issues, and interoperability issues. So in terms of the requests from multiple payers, providers receive so much data from the many payers that they contract with, and they're usually in different and fragmented formats. And it's, as you can imagine, a provider doesn't typically ask a patient which insurance they have when they go into the exam room. And therefore, you can imagine that they're not going to take the time to log into each payer's portal if they have one, or look at an Excel spreadsheet to see if their patient that they're seeing might be in there and might have care gaps. Another issue is related to care gaps. So we all know that they're not always accurate when they're only based on claims data. Some things are documented in the EMR. For example, a mammogram that might be done at an off-site radiology center, while the report might be stored in the PCP's EMR, but there would probably be no procedure code for it that would have appeared on a claim because it wasn't done at the practice. So therefore, in the claims data, it looks as if it hasn't been done and that there is a gap in care for this particular woman over the age of 40. And then in addition, a lot of payers have siloed databases internally, and providers experience multiple reports, sometimes in different formats by product line from the same payer. And then lastly, the very big category of interoperability issues. I hear a lot from payers the desire to push their care gaps and claims data information directly into the EMR. But the EMR market is so fragmented. There are at least 300 vendors out in the market and multiple different versions of each vendor's system in use among provider organizations. But beyond that, there really doesn't exist a standard to transact care gaps like there does for claims data and lab results, for example. So it's really hard to imagine any given provider, payer, and all of the providers that they contract with being able to push data into every EMR and expecting it to look right in the EMR, and the cost that would be. Similarly, it's difficult to retrieve the supplemental data that payers need from EMRs too. It's very expensive for practices to get their EMR vendors to output data. And really, all but the largest practices and hospitals lack tools like interface engines to transform the data into the format that works for the payer and to strip the data that comes out of their EMR from the patients that aren't members of a particular payer plan. So these are challenges that practically make it very difficult to share data, in addition to consent issues and data governance. Recently, I was at a conference, and there was a speaker from Boston Medical Center Health Plan who said that they found the scale of the challenge of this data sharing and interoperability such that they needed to invest in new solutions rather than try to evolve and work with their existing capabilities and legacy databases. So those are some of the challenges that are practically experienced in the market. And I'm going to pass it over to the next speaker, who will talk about a very specific case study where the collaboration has been very successful between payer and provider.
Thank you, Suzanne. I'd like to welcome Dr. Bill O'Connor, our next speaker. Dr. O'Connor is Chief Medical Officer of SPH Analytics. He has more than 20 years of healthcare experience focused on population health, clinical analytics, operations, product development, strategic planning, and sales. He holds a Doctor of Medicine degree from New York University School of Medicine and has practiced within the area of orthopedic surgery. Dr. O'Connor brings to SPH Analytics unique industry insights through his tenure at Orion Health, the leader in HIE within the healthcare market, McKesson Corporation, PricewaterhouseCoopers, Zinx Health, and Allscripts. Welcome, Dr. O'Connor.
Thanks, Terry, and thanks, everyone, for joining us this afternoon. Go to the next slide, please. I wanted to spend a few minutes, and you heard Roki and Suzanne talk a little bit about what is going on in the market, and what I wanted to do is make it a little bit more real world and talk about a specific customer that we're working with where we are putting some of these programs in place. Next slide, please. So the customer I wanted to talk to you about today is Blue Cross Blue Shield of Louisiana. We've been working with them for about 4 years now on a clinical program called Quality Blue Primary Care. And Blue Cross Blue Shield of Louisiana decided to put this program in place for a couple of reasons. First, they felt like they had a lot of opportunity to help folks with chronic disease. The rates of chronic disease in their state were very high, and they felt like they had a good opportunity to help those patients. The other area of opportunity was they were spending a lot of money as well. So as ranked by CMS, they had quite a few of some of the highest cost areas in the country that we were spending in Louisiana. So an area of opportunity there as well to improve cost. And so we partnered with them. We installed one of the solutions we're talking about, our population care solution. And, you know, the primary drivers for this, other than trying to improve, obviously, lowering costs and increasing quality, Blue Cross Blue Shield was really trying to get their arms around a couple of things. One, and Suzanne covered this a little bit earlier, getting access to the clinical data. More and more we find health plans are trying to become as mature in dealing with clinical data as they are in dealing with claims data. So that was one of their goals as well. And the other one was the obvious goal as far as improving quality was closing care gaps. And that's really what our population care solution is designed to do. It integrates with multiple and disparate EMRs, aggregates all of that data in one place, and then we can run our quality measure and our care gap algorithms across that data and are able to produce the care gaps for the providers in real time as they're seeing the patients such that they can close those gaps. And the results of this program have really been extraordinary. In my 20 years of doing this, this was one of the best clients I've been involved with and had one of the most dramatic results I have ever seen. So you can see on the right-hand side of the screen there, $27 PMPM was saved. We ran this program initially. The program is larger now, but initially it was about 135,000 patients. That saved Blue Cross Blue Shield of Louisiana $44 million in the first year of this program. So an incredible savings. And the results they got were good too as far as clinical quality. 25% improvement in diabetes care, improvement in hypertension and vascular disease, a vast improvement in kidney disease. So not only were we reducing the cost and increasing the quality, but this had a real impact on the lives of the folks that were part of this program and living in Louisiana. This was someone's mom or dad or grandma or grandpa that didn't have to go into the hospital and got better care. And that's really tied to where the savings was coming from. We had greatly reduced hospitalizations, greatly reduced emergency department visits, actually a slight increase in pharmacy costs because folks were being more compliant and taking their medications, and also an increased number of primary care physician visits as well, which helped people stay on track with their program and greatly reduce the number of gaps in care that they had. Next slide, please. So just a couple of key points here. Again, a big opportunity that they had. 60% of the top 10 highest cost regions identified by CMS are in Louisiana. So they were spending a lot of money and, again, lots of opportunities. So 36% of the population had one of the 4 chronic diseases that they were going after from the start of the program. And how they use our application and how they drove the use of population care is very interesting. So it's sort of a neutral playing field. So although Blue Cross Blue Shield Louisiana is a dominant payer in that state, we are aggregating data from all patients, either from other payers, and the providers are able to use the application and benefit those other health plans and patients in those other health plans as well. So we're sort of that neutral aggregator. We're ingesting all the clinical claims and pharmacy data we can get our hands on. The solution is free to the providers, and they can use it across all of their patients. But not only are the providers out in the field seeing patients using it, the providers that work for Blue Cross Blue Shield of Louisiana that are part of that organization use the solution too and can help drive some of the change that they're seeing across the program. Next slide, please. So a lot of you are probably wondering, how did they get the providers to do this? It's difficult enough at times to have physicians and other providers use an EMR, and now you're asking them to use another application as well. And they did this in a couple of ways. First, Blue Cross Blue Shield was willing to pay care management fees for the chronic patients, and they based those payments on outcomes, not just simply participating in the program as part of the process, but the actual outcomes. So it really drove the providers to be competitive with each other and try to score higher and move into that top tier of reimbursement. They also said they weren't going to increase the fee-for-service revenue for these providers unless they participated in the program and shared their data. So a couple of really interesting ways that they drove participation in the program, and really participation was off the chart. The demand exceeded the capacity to sign up folks quickly enough for this program. So as it stands today, we have over 50 clinics that are signed up, which is over 700 providers representing 19 different EMRs. So our ability to aggregate that data, extract the data from the EMRs, and put it in our database, and then run gap in care algorithms across that really worked well for them. And we did implementations across that entire state. And geographically, the practices that are associated with this program, north, south, east, west, are all over Louisiana, and it has been a tremendously effective program. So thanks for allowing me to share that with the group today. We're really proud of these guys. They are just an absolutely amazing client. They have done an extraordinary job and have really improved the health and welfare of the population of Louisiana. So we're proud to get a chance to work with them. Next slide, please. If you want to read a little bit more about it, there are some great resources here. That first link in particular, if you go to that one, bcbsla.com and the Quality Blue Primary Care Program, you can see a lot of detail about the program. You can see some of the measures, the quality that they're trying to drive for, how they're tiering the providers, et cetera. So lots of good information on there, and I encourage you to check that out. Next slide, please.
Hi, so it's Suzanne. I'm going to just cover this. Thank you, Bill. So we wanted to just dive in a little deeper and explain some of the very important technical requirements when you're undertaking the exchange of clinical and claims data between providers and payers. And then we'll move into a quick demo of our particular solution. So this diagram represents SPH's data platform, which we call Nexus. It's a next-generation data acquisition, aggregation, and enrichment platform. And basically, the data flows from left to right and then up into applications that you see in the cloud at the top. So apart from the basics of retrieving data from multiple EMR systems and curating it in a way that's meaningful for end users viewing the applications, there are a handful of important features that you would want in any solution that's doing this work that I wanted to point out. So the first is the idea of pulling data from EMRs and direct database integration. So over on the left, you see these databases that represent different types of systems and multiple EMR systems. If you rely on the output that comes from the EMR system, for example, in the CCDA standard, not only does this standard vary wildly from one EMR to another, which causes the recipient to have sophisticated tools to parse out the data and standardize it, but more importantly, it doesn't contain typically all of the data elements that you need for quality measure and HEDIS measure satisfaction. So one example was the mammogram that I mentioned earlier, whereby the mammogram may have been done, but it's kind of listed, it came in by fax or direct secure message, and the report is there, but there's no discrete piece of data in the PCP's EMR that says the mammogram was done. The next piece that's really important, which you can see kind of towards the bottom of the middle of the screen, is deduplication. So a lot of EMRs send out a full patient history every time the patient has been to see the doctor. And whatever tools you use to retrieve data from EMRs need to have pretty sophisticated deduping algorithms and logic to separate that out so that they're not displaying 10 prescriptions for the same drug, which may be unclear whether it was actually 10 prescriptions or just one prescription that was duplicated 9 times. Some of you may have heard of the term semantic normalization. That is important too. It's represented in the bottom of the slide through crosswalk services and terminology management and data normalization. And that's the process of taking whatever codes come in from a particular hospital or practice, which may not be industry standard, and mapping them to an industry standard code like LOINC or SNOMED or ICD-10 or NDC, and ensuring that whatever analytics is run on the data is, basically comparing apples to apples. Up on the kind of the top left of the enterprise data warehouse box is something called optimal trait identification. And the important thing about that is when you are, whether a provider or a payer, using data to satisfy quality measures, both organizations are incented to have their quality be as high as possible. So you want to pick the data that ensures the highest possible quality marks. And an example of this is if a patient has multiple blood pressure readings in a single day or a single encounter, the software should be smart enough to pick the reading that has the optimal results to best satisfy whatever quality measures the blood pressure results go into. And then lastly, something important that I wanted to point out, over on the right, the export, when you have this valuable, aggregated, and normalized data in a platform, you have to easily be able to retrieve it for other purposes. Payers will have all sorts of other things that they want to do with the data, internal data warehouses, and one of those things would be, of course, the need to retrieve what's called supplemental data to, to internally make sure that their HEDIS measures are being met. So being able to export it, have an open system, and transform it into whatever format the particular recipient or the particular payer needs is important as well. So that is kind of the under the hood foundation of a system like this, and particularly of our system. And I'm going to pass it over now to Sarah Zawicki to show you what's above the hood and what the user would experience.
Thank you, Suzanne. I'd like to introduce Sarah. She is our Vice President, Clinical Product Management at SPH Analytics. She leads the product management team in developing new solutions for the population health and quality measure marketplace. Prior to SPH, she served as the Vice President of Clinical Operations and Product Management at Lifeline Screening and Community Healthcare, and was responsible for driving the expansion of clinical services to Medicare beneficiaries and patients in the 50-plus demographic. Sarah holds a Master's of Public Health and a Master's of Business Administration from Emory University and a Bachelor's in Biology from Northwestern University. Welcome, Sarah, and if you'll bear with me a moment, I will pass the ball over to Sarah to do the demonstration.
Thank you, Terry, and thank you, everybody, for joining us this afternoon. I do want to thank Roki and Suzanne and Bill also for sharing the appropriate content for our webinar today, and really just reinforce here in this demonstration how SPH Analytics Patient and Chronic Disease Registry tool, our population care tool, which includes the underlying data warehouse capabilities that Suzanne just went over, as well as this front-end application that I'll demonstrate, how it addresses two, key business challenges that are facing payers today that we've stated in this webinar. The first, of course, being that payers need clinical data from the EHR to help supplement claims data to address HEDIS and STAR measure calculations. This is a very big challenge. Payers are heavily investing, in manual chart abstraction. Practices don't have IT resources, as well as just every EHR is different, and instances, of course, are capturing different workflows. So it's a logistics and technology challenge to be able to get this data. And the second, of course, is that payers need to engage with providers to close care gaps and do it proactively, so that it's not a retrospective look at claims just to measure what the result is, but it is a supporting of their practices to be able to work to improve these, closing these care gaps and important screenings and wellness practices that will improve outcomes down the line. So what I wanted to demonstrate quickly was the solution Population Care. This is a solution that is in its 7th generation. It's been around for over a decade or so. It helps over 5,000 providers manage primary care and wellness for adult and pediatric populations for about 10 million or so patients. So it's not a new solution, and it's one that we have iteratively been making improvements to over the years as clients as well as the environment and market needs have changed. The source data for this tool is predominantly ambulatory EHR systems as well as practice management systems, but we are able to supplement with claims and pharmacy claims data as well. This, another important feature of this is that it is all payer data. And so with us extracting clinical data from the provider's EHR system for all payers, then you have a better adoption on the provider side instead of having them log into 2 or 3 or 4 different payer-specific, portals. And that is one of the benefits of a solution like this. It aggregates data across different systems, but also extracts all payer data. So it is about managing your total patient population, not just managing one at a time based on specific memberships. The tool also is very sophisticated in its ability to organize the structure as well as give permissions. So what I mean is, if the organization is broken out into geographic regions or different practices or by TINs, there's a lot of flexibility in the way that the data can be reported. And regarding permissions, we also have significant capabilities in rules-based and permissions for access to PHI level data. And so in Dr. O'Connor's example of Blue Cross Blue Shield of Louisiana, they are using the application at a sponsor level and would not have access down to a PHI level, but instead are looking at aggregate results, versus individual practices would be able to drill down to patient-level NPI. So on this front dashboard here, there are a couple important widgets that I just want to cover, and then I'll go deep dive into basically the core of the patient registry and chronic disease registry that's the foundation of this solution. So the care opportunity summary here is a snapshot of the entire population that's been extracted from the clinical EMR and broken down into 16 different disease and wellness suites. There are over 120 some measures that are subsetted and belong to each of the disease and wellness suites. And as you can see, between asthma, breast cancer screening, and colorectal cancer screening, these are the major drivers of chronic disease, of recurrent costs, of comorbidities, addressing a primary care population, both adolescent, pediatric, and adult populations. In addition, we can take in the practice management scheduling feed and tie those patients who have care gaps to an upcoming office visit. And that's the feature that is widely used in our clients who are using the tool, is to be able to understand and with a quick front-end application, print out that list of open care gaps so that they can really optimize that office visit and tie those into the practice management scheduling system. In addition, there's a couple of other widgets at the bottom here, being able to customize your dashboard to view the most important measures for you, a comorbidity map that also plots and stratifies the population based on disease burden and care opportunities, and also a tool to be able to reassign patient to physician attribution when care management fees are involved and when there's a attribution that must be closely monitored. So let's drill down into the care opportunity summary a little bit deeper. As you can see, again, these 16 different disease and wellness suites are then broken up into additional metrics that support these diagnoses. So for example, for heart failure here, we are measuring all of these different metrics, everything from medication adherence to influenza vaccine for anybody who has a diagnosis code of heart failure. Same thing goes for chronic kidney disease, diabetes, hypertension. So again, a lot of the chronic conditions that are really driving recurring costs. They also go into those that you want to monitor for rising risk. But there are also those that have a lot of metrics surrounding them, whether that's HEDIS metrics or STARS, or even at the provider level, those MIPS measures. So the way that you interpret this tool and use this tool is a little bit different than just saying the measure is met or not. And so I want to explain what the green and yellow and red and the gray indicate in each of these metrics. And so if I just go to my trusty legend here, green means, of course, that metric is met, that it's meeting the compliance rate, meeting the measure specification. Yellow means that it's due within 60 days. So the tool is really meant to preempt care gaps before they actually happen. And so if something is calculating that it's something that needs to be done on an annual basis, then the tool will indicate by using the yellow color that it's due within 50 days. So 60 days, you can proactively prevent it from becoming a care gap. Red obviously means that the outcome is out of range. and gray is that the data is incomplete or the data is too old. So let me just take a specific example. I'm going to pick this one here, blood pressure less than 140/90. Systolic and diastolic blood pressures are something that are difficult to obtain at the payer side. It's not something that's reported on the claim. It's one of those vitals that there's a lot of chart abstraction and hunting for just for that systolic and diastolic. So I'm going to show you how easy it is to view that information in this population care solution. So again, the way to interpret this bar is that 51%, so this 2,223 patients out of 4,185 have met this measure. But if I wanted to drill directly into the 27% of patients where their systolics and diastolics were out of range, with a click of my mouse, I can immediately go down to a patient list. And I view in addition to demographics, who the attributed clinician is, I can actually view those blood pressures that I have abstracted out of the EMR. And if I want to go one step further, I'll look at Ms. Kelly's patient care summary here. Not only can I view her record of her blood pressures, but I can see all the other care gaps that are open for Ms. Kelly Adams here. So for Ms. Adams, she belongs to 4 of the population care disease suites: breast cancer screening, cervical cancer screening, colorectal cancer screening, and the hypertension suite. Breast cancer screening is another one that's very difficult for payers to get mammogram information. And so here, with just being able to expand, I have a record of when my documented mammograms were for Ms. Adams very easily, and I can see that she is compliant for having it done in the last 24 months. Same thing goes for hypertension. I see that, I drilled down into this patient care summary because her blood pressure is out of range, but let me just take a look at where she was before, and this is a good case to follow because she's been increasing in her blood pressure over the last couple of years, and now, she's in the red because she's out of range. And so, again, one great thing about this is regardless of the EHR, regardless of the payer, I've got one centralized repository and longitudinal records, particularly of vitals, as well as laboratory results, all at my fingertips. I can batch print this patient care summary. I can add notes to it for my case manager that I have one complete record, and I didn't have to go and dig down into multiple EHRs or use, multiple, people or staff to do it. Another feature that I want to focus really quickly on is my ability to filter and drill down on very targeted subsets of the population. And so if I wanted to just select certain groups, if I wanted to just select certain clinicians, and let me take another suite like the diabetes suite and maybe only filter and look at every measure that's related to hemoglobin A1C, which again is another HEDIS measure and one that's difficult to capture because lab results are also not found on the claims. So here, with a click again of just my filters, I have filtered down to just look at A1C results for these groups and these clinicians. I can also look at the performance rate of these measures, as well as very quickly look at a 12-month trend of where the changes have been for these measures. And then probably, since we're close out of time, let me just talk about one other quick capability that's very pertinent for collecting and aggregating information, and that is the ability to use a front-end direct data entry tool. And so we do have clients who do not have electronic health records, and those pose significant challenges, I'm sure, for calculating HEDIS and STARS, but also for them not having the ability to, have a population health tool to manage their population. Well, this tool enables you to manually go in and viewing patient traits and add everything from vitals to social history, medications, lab results, meds, so that the next time that this information reprocesses and retrates, then these patients would get credit for those measures. And even in the absence of an electronic health record, we are collecting this data, storing in our data warehouse, and the practices can proactively work to close care gaps. So again, just in closing, really a couple key highlights. population care, this solution really, supports not only fee-for-service, but also fee-for-value. It enables you really to view care gaps throughout the year and to proactively improve them instead of, a retrospective claims analysis and then retrospective kind of chart review. So it really reduces that need for the costly chart review, but also makes, for the payer side, really the audit process more efficient because you're able to drill down into specific populations and be able to, deduce the gaps from the EMR information that has been abstracted and is all kind of readily available in a web-based solution. So I'm going to stop there. I know I didn't leave a long time for Q&A, but I hoped I was able to kind of demonstrate how our solution really addresses the key payer needs and business challenges.
Thank you, Sarah. That was very enlightening. I'd like to open up the webinar to questions now. We have several of them lined up, and I know we're near the end of time. What I will propose is that we go ahead and answer the questions that we have, and as we are recording this, anybody who needs to sign off at any point can, and we will make sure to send out the recording and the slides within a couple days so that you have the full information. Thank you again, Sarah. So the first question I have lined up, and do note that anybody who has additional questions, please go ahead and type them now into the Q&A tab of the WebEx portal, and we will get to them as soon as we can. So the first question I have is, what EMRs does SPH's system connect to?
So I will go ahead and take that, Terry. So we can connect to, any EMR system that's using standard interface and format, but we have very specific experience in mapping and extracting specific and unique data elements to more than 45 different EHRs. And so that does include all the major ones, and including the Epic and the Cerners out there.
Thank you, Sarah. Next question. Would your system reduce the need for a payer to do on-site chart reviews?
Yeah, I'll take this one. Yes is the short answer, most likely. We work with several payers in retrieving EMR data and reformatting it into what they call their supplemental payer data exchange format, and that provides them the electronic data from the EMR that they are typically looking for when they do chart audits on site. It might not have everything that they may want to view in a chart, but it should certainly reduce the need for on-site chart reviewers.
Thank you, Suzanne. The next question. Right now, some of our practices can only submit a maximum of 4 diagnoses. Will we be able to submit more than this using SPH?
Tara, this is Sarah. I can go ahead and answer that. So the answer is yes. So we definitely have heard from multiple payers that there are clearinghouse limitations on how many ICD codes they'll process on the claims. And so that, of course, limits the ICDs being used for risk adjustment as well as, HEDIS and STAR. Usually we are going ahead and loading more than 2 years of historical diagnosis codes and all of the diagnosis codes. So we would definitely be able to capture more than the 4 or 6 in which has clearinghouse, limitations.
Great, thank you, Sarah. Next question. Can SPH help me with my cost and utilization trend?
This is Sarah again, Terry. I'll go ahead and address that. So the answer is yes. So, in addition to loading clinical EMR data as well as practice management data, we are in the process of loading claims information and using industry standard tools like Milliman HCG Grouper and Milliman MARA to do expenditure grouping as well as utilization metrics and predictive analytics based on claims and expenditure data.
Thank you, Sarah. I think we're almost at 2 o'clock. Let's just take one more question. I've got this one here. Will this help me understand my MIPS quality measures?
Okay. Terry, this is Sarah. I'll go ahead and take that again. So, yeah, so many of the, the 120 some measures that are within our population care tool are aligned with MIPS. However, we also do have a different application because we are a qualified clinical data registry, and all this data is stored in a central data warehouse that is able to calculate standard MIPS measures as well as, ECQMs in supporting programs like CPC+.
Great, thank you. Well, I'd like to thank all of our speakers today, Dr. Roki Chauhan, Suzanne Kogan, Dr. Bill O'Connor, and Sarah Zywicki for a very enlightening presentation about payer-provider collaboration to achieve the triple aim. As a reminder, we will email the slide deck from today's presentation as well as a link to the webinar recording to all of our attendees within the next couple of days. I'd also like to extend an invitation for you all to join us for our next webinar that happens to be on Wednesday. It's about maximizing commercial payer incentives by closing care gaps. It will feature Susan Helton, who is Executive Director of the DeKalb Physician Hospital Organization. We also have a large schedule of webinars that we do throughout the year. We have another one that's coming up in November on STARS improvement. The date hasn't been set, but please watch our website at sphanalytics.com/webinars so that we will publish that date as soon as it has been set. On behalf of SPH Analytics, I'd like to thank our speakers again and to thank all of you for joining us, and I hope everyone has a great day.